In this module, we will provide guidance for practitioners who are working with patients who are experiencing pain. With heightened focus on pain management and the concern about preventing addiction in the patients and the community, this topic becomes more and more complex. Discussing the issues with us today is Dr. Nicole Keegan. Dr. Keegan is an advanced practice nurse and graduate of Monmouth University's DNP program. She is the Director of Pain Management Services for Monmouth Medical Center and is the sole proprietor of the Pain Relief Center of Central New Jersey, an outpatient pain practice established in May of 2014. Dr. Keegan, thank you for being with us today.
Thank you so much for allowing me to participate in this educational program, helping the nurse practitioners be educated on pain management. It's definitely a topic that I'm very passionate about.
So, dealing with patients with acute and chronic pain can be extraordinarily difficult for healthcare providers. So maybe you could give us a little bit of a background of your approach?
Well, it's always about the patient's perception and making sure that you take the time to listen to the patients. Regardless of whether the patient's in the inpatient or outpatient setting, we want to make certain that we allow them to explain about their pain, listen to them, and not judge them. We want to make certain that when we talk to them that we don't express our personal opinion. Some patients can say that they have a 10 out of 10 pain and they can be texting or in a conversation, watching television, but that doesn't mean that they're not in any type of pain. We could have a patient's pain is perceived by that person at that moment in time. If somebody has a shard of glass on the bottom of their foot and they're walking around, that could be extremely painful. And if you would ask them if they could rate their pain, they might tell you that it's a 10 over 10 at that time as they're experiencing it. However, on the opposite side, you could have somebody that just had their leg amputated and they could turn around and say that their pain is a 10 out of 10. But again, it doesn't mean that one person's pain is worse than the other, and we would be wrong to judge that one is worse than the other as well. So it's definitely a matter of keeping that in mind, being non-judgmental when you're trying to ascertain and put a pain plan together.
I understand that there is a comprehensive pain assessment. How do you conduct one of those?
Well, when you do a comprehensive pain assessment, you have a conversation with the patient, whether it be inpatient or outpatient, and you talk to them about their pain. You ask them to describe it to you, when it began, whether it was the results of a surgery or a trauma, or a work-related incident. I usually ask the patient to point to where their pain is, if they can do that. I ask them if it's constant or intermittent, if it's sharp or shooting, if it's burning or stabbing. I ask them if it's has electricity in the pain, if it's like a gnawing pain, and then I try and figure out in my head if it's a pain that's what we call nociceptive or something that's visceral or neuropathic. And those different types of questions help me to formulate a pain regimen. I want to know from the patient whether or not something makes the pain better or worse, what they've used in the past, if this is a constant pain, and if it awakens them at night.
Is your approach then different when you are dealing with either inpatient or outpatient setting?
It can be a little bit different. The approach can be different. The patients that are in the inpatient setting, we don't do any type of screening tools for them. We do view each patient, whether the inpatient or outpatient setting, on the state website, NJPMP Aware. So that gives us some sort of information about the patient's pain history, whether they have prescribed medications on a regular basis, whether or not they may be doctor shopping or hospital jumping. So that does give us a formulation. And then it's important to look through the history and physical, any lab tests that they might have, any imaging, different consultation reports to try and get a better picture about their pain.
So maybe you can then tell us a little bit about what the first visit is like. What are some of the tools specifically that are used, or what are some of the screening processes? And as a result, then how do you educate your patients, again, about pain management then?
Whether the patient is on the inpatient or the outpatient setting, we always encourage to use what we call a multimodal approach. We start out with trying to hit different receptors, whether that may be with acetaminophen or muscle relaxers if the patient's having spasms. We may need to add some opiates. We have to focus based on what the patient tells us. If they have constant pain or intermittent pain, if they have neuropathic pain. We want to be able to ascertain whether they need a long-acting pain medication if the patient is having chronic pain. Intermittent pain, we might use short-acting pain medication. If they're having muscle spasms or achiness, we might use a muscle relaxer. If they're having neuropathic pain, we might use some type of neuropathic medication like gabapentin or Lyrica. So it's very important that we ascertain that information in trying to formulate our pain plan.
Now, what are some of the differentiating factors between that sort of scenario, that education process, in an inpatient scenario as opposed to an outpatient scenario?
I'd like to just touch base on a little bit of the similarities first. So we definitely want to make certain that we set realistic goals. Like I said, in the acute patient, it might be just turning in bed, coughing, and deep breathing. Whereas in the outpatient setting, it might be being able to ambulate 50 feet or 100 feet. It might be to go to work and function every day. So it's about setting realistic goals, figuring out what those goals are for that individual patient, and setting some limitations with activities, having a constant discussion with them, making certain that they understand that they may not be pain-free, the goal is to try and calm down the pain, not necessarily make them pain-free. That might be an unrealistic expectation.
Now, once you are successfully able to educate the patient themselves, do you have any tips about how you would educate family members, let's say, in about, again, pain management?
Well, I usually explain to the patient and to the family that it's all about prescribing safely and taking your medication safely. I educate them about trying to possibly write down, keep a pain diary and focus on when they need their medication, understanding that the pain medication takes about 45 minutes to work, so they might have to time it and base their activities around the pain medication, that they need to keep the medication safe out of, not keep it in their bedroom or their kitchen cabinet or the medicine cabinet. If they have any unused pain medication, that they need to dispose of it at the police station in the medication dispensary box. They need to understand that they're being prescribed a medication that's very strong and can be at risk for addiction, not only for themselves, but for other people. And so they're responsible for that medication as well, and they need to understand that.
How is the outpatient visit different than that of an inpatient visit?
In the outpatient visit, we do use screening tools. We use the SOAP screening tool for patients that we're thinking about instituting an opiate regimen, and then the CALM screening tool, which is used for patients to screen them to make certain, to see what their risk would be if they would demonstrate any aberrant behavior. In addition to the outpatient setting, we use a narcotic agreement. My agreement includes a pill count. The patient has to understand that they are only allowed to use one pharmacy. They are advised that I'm going to be checking their pain regimen on the state website, that they're not allowed to take any more medication than prescribed. It's important that they understand, and it's reviewed with them, that if there's an emergency situation, let's say the patient had a kidney stone and they had to go to the emergency room or had a dental procedure done, that they have to either contact me immediately after that situation happens, or if it's a planned surgery, that we discuss it beforehand. Usually I will tell them that I will adjust their pain regimen for some kind of elective surgery that they're having or a dental procedure, but that it's important that they take the medication as prescribed that they're responsible for their pain medication. If it's lost or stolen, that they would have to fill out a police report. So everything is broken down very explicitly. It's important to review it at the visit and to have them re-sign the contract on a yearly basis in the chronic outpatient setting.
So based on this conversation of risk, what are some of the red flags, particularly if you're encountering or potentially encountering a drug-seeking patient?
Well, one of the things that I also do in the outpatient setting, we do it also occasionally in the inpatient setting, but absolutely in the outpatient setting, is random urine drug screens. We do a urine toxicology for the patient at any given time. Sometimes I do them back to back from month to month as to not to get the patient off guard. I review the results with the patient. When you're doing the urine toxicology screen, there are a few things that you want it to look for. First and foremost, you want to make sure that the patient is taking the prescribed medications, and not only the opiates, but all the other medications that you're prescribing for them. If they're on an antidepressant, if they're on a muscle relaxer, if they're on a neuropathic pain medication, all those medications should be listed on the drug toxicology screen. Some of the other things that you're looking for is to see whether or not they're taking any illicit type of illicit drugs, rather, heroin, cocaine, marijuana. Some people are okay with smoking marijuana on the tox screen, and some of them are not. That's a personal preference. As long as the patient has been prescribed medical marijuana, I'm usually okay with it. But with respect to on the street marijuana, I usually encourage them not to do that. One, because it is illegal, and two, nowadays I'm worried about the marijuana being laced with different types of drugs like fentanyl and heroin. In addition to the urine tox screen, some of the other things that you're looking for to see is if patients are taking other prescribed medications from friends and family. You might be giving them, let's say, Vicodin, and they're positive for Dilaudid. So that gives you an indication of whether or not they're perhaps maybe running out of their medication sooner, whether they're selling their medication. So those are the different things that you're looking for with respect to the urine toxicology screen. Some of the other red flags that I'd like to mention is if the patient constantly asks every week for a different regimen. They tell you that Percocet is not working, and then you change it to morphine, and then they tell you the morphine is not working, and they want another medication the following week. So those are some of the drug-seeking behaviors. If you're asking for a urine toxicology screen and they're most times unable to produce a urine sample. I have a company that comes in, so I'm able to do an oral swab. So there's different ways to try and work around that. Patients that run out of medication early, that are not compliant with the PMP aware because they're getting different other prescriptions or multiple pharmacies. Those are some of the things that kind of give us a red flag that they might be having some issues with over-medicating, selling, or illicit drug use.
So based on the presence, let's say, of some of those red flags or perhaps their previous health history, how do you enter into conversation with a patient that they may be at risk for abuse?
Well, I'm always honest with the patient. It's always important to have an honest conversation and to build a trusting relationship. I explain to the patient that my goal is to try and work with them and help them manage their pain. However, I have to do it and keep them safe at all times. So once I get the urine toxicology back, or if I'm suspicious that they might be selling their medication, I usually present them with the report. We discuss it. Sometimes they may be honest with me and tell me that they ran out of their medication early because they had increased pain because they pulled out their back and they took extra pain medication. They might tell me that they ran out of their medication and took their wife's medication, or they borrowed something from a friend. So whether or not I give somebody a second chance depends on the situation. If the patient had an illicit drug like cocaine or heroin, usually I do not give them a second chance. There's really no excuse for using an illicit drug. If the patient has had exacerbation of pain and they ran out of their medication early, I usually explain to them that they need to contact me before they start escalating their dosages, that they shouldn't self-medicate. I usually give them an example, perhaps, that if they had taken their blood pressure and their blood pressure was elevated, they wouldn't start doubling up on their blood pressure medication, that they would contact their cardiologist or their primary care physician. Well, it's the same thing with pain management. You know, it's a chronic disease, most times for the chronic pain patient, and they need to be managed appropriately. And they should call me and have a conversation with me before they start escalating their doses, because that's how the risk of addiction and dependency can take place, and it puts them in a bad spot. So contacting me before, if it's a problem that continues to happen on a regular basis, that might be, you know, another red flag, and I might have to suggest to them that I really believe that they might have some form of addiction tendencies. I might have to discharge them from my practice and refer them to an addiction specialist so that they could get help.
Now, the individuals who are currently viewing this module have reviewed the PMP website. And you've mentioned it quite a bit thus far. Do you find that this has been an effective tool for your practice and within your practice?
I look on for all my patients that I prescribe, whether they are in the hospital or outside of the hospital. I definitely review them all on the PMP website.
Can you think of a specific case study, perhaps, or example again where you've really seen the effectiveness of utilizing the website?
I've had a patient in the hospital a few years ago who specifically had come into the hospital overnight and had told the residents and the attending that he was taking very high doses of OxyContin and methadone and oxycodone. And the staff, unfortunately, didn't check the PMP website. That patient was prescribed that medication based on what he had told them. And unfortunately, the patient started to experience some respiratory depression. So when I came in, I had gone to the website and I looked everything up, and we saw that the patient was not on any of that medication. And in fact, he hadn't been on that medication for about 8 or 9 months prior. So that is one of the reasons why he was having a reaction and suffered some respiratory depression. So that website does provide a lot of information, and it's important to verify that so then you could have a conversation with the patient despite what they're telling you.
Do you have any suggestions then for tapering?
I usually try to do tapering with my post-op patients. I usually prescribe a medication and then bring them back every 2 weeks, starting to lower the dose a little bit by little. I usually, if they're on a long-acting pain medication, perhaps OxyContin 20 every 12 hours, and let's say Percocet 10 every 4 to 6 hours. I usually try and lower the long-acting pain medication, the OxyContin, by, let's say, 10 milligrams every 2 weeks. See how the patient does, make sure that their pain is tolerable and that they can function with that. I usually explain to them that every time you lower them, it does take several days for the patient's receptors and for them to get acclimated to the lower dose. The first few days might be a little bit harder, but then after the few days, then they will start to feel better.
Now, as I understand that there are new laws for prescribers when it comes to, again, prescribing this sort of medication. Would you be able to run through perhaps some of the new guidelines, again, as listed out in this new law?
The new guidelines refer to patients with acute pain, and for a patient that has not had any pain prescriptions within the past year. They refer that to someone that's had, it's the initial prescription. So if the patient, you have to review them on the PMP website. If they have not had any pain medication within the past year, and they refer to that as the initial prescription, the patient can only have a 5-day supply of the medication. They're not allowed to be prescribed any long-acting pain medication on their initial prescription, and they recommend that we use the lowest dose possible. The That can be a little bit challenging depending on the patient and the procedure or what the acute pain is about, but it's something that we have to work through to keep our patients safe.
Now, is there any advice then that you would give to a new prescriber?
So yes, I would definitely recommend that for all patients, you need to review the PMP website to make certain that they're, whether or not they've had any previous pain medication prescribed to them or not, and to see whether or not the patient is doctor shopping or not. Always start out with the lowest dose. Use the CDC guidelines of non-opioids as well. Make certain that you recommend adjunct therapy as far as heat or ice. Explain to them that they might have to have a schedule as far as limiting their activities, so that, you know, if they're going to take a shower, they're at home, they need to take their medication, let it work for a little while before they shower. When they're done, they might have to rest before they do another activity, pre-medicate before they're starting physical therapy. So it's always a matter of educating your patient, giving them the guidelines, explaining everything to them, using different medications like acetaminophen in between their pain medication, and making sure that they understand that they might not be pain-free, but the goal is to try and allow them to function better and have better quality of life.
In addition, we've mentioned this PMP website quite a bit. Are there any other resources that you'd be willing to, or that you know of, to assist practitioners in pain management assessment?
There's a few different websites that they could use. One of them is Pain EDU, ASPMN, which is the American Society for Pain Management Nurses. There's the American Association for Chronic Pain. There is the Institute for Safe Medication Practices. So there's a few different resources that are available for guidance with patients with chronic pain, the screening tools, and how to handle different scenarios.
Dr. Keegan, thank you very much for all the information today. We do appreciate you being here with us.
Thank you very much again for allowing me this opportunity.